Am I doing it wrong? Sorry, guys. What I want to do is talk in general about how you might consider improving clinical outcomes and then use our mock code training program as an example of how we did this. One of many examples how we did it at OHSU. Is it okay? Is it this one? Oh, good. Okay. So when you think about developing a sim that's intended to help improve clinical outcomes, it's important ahead of time to start thinking, what am I trying to do? How am I going to get there? The first question is, what is the clinical outcome we hope to achieve, right? Dream big, but then start thinking of, well, okay, that's great, but how are we going to do it? And probably more importantly, that this is the part that often gets forgotten, is how are we going to know if what we're doing is helping, right? I think we all know that there are ways to do simulation where you check a box, or any education. We educated people, and it's more of a, we pushed out information, but do we know that the learning happened, and do we know that it translated into clinical practice? So I always like to think up front is, how are you going to measure improvement? And I want you guys to think not only of simulation metrics, but also your clinical metrics. How are they going to translate to each other? And then I want to stress also the importance of closed loop and continuous improvement, right? So we set up a sim, we do some training, we show that the training works in sim, then we figure out if it's translating to the clinical side, and what is the clinical side seeing as other areas of improvement? Or we trained this, but it's still not happening. How do we feed that back in and adapt the sim so that we can do better? So, there. Maybe I just have to point it in the right direction. Okay, how about this? I'll stand over here, that way I can automatically. So let's talk about Code Blue. Everyone knows, you've seen it on TV, you see it in your work depending on where you are, but a patient in the hospital may go down and having a cardiac arrest. We call that a Code Blue, and cardiac arrest is thankfully a low frequency, but unfortunately a very high risk situation, right? If you don't do anything, there's a 100% chance of death, but if you do something, you might actually turn that around. Unfortunately, and this is some of updated literature, depending on where you are, only up to 27% of patients will survive, and that's actually good data. And those who survive with good neurologic outcomes is a much smaller percentage. So we want to improve this. And in the US, in-hospital cardiac arrest accounts for up to 750,000 deaths per year. So it's an important problem. I don't probably have to convince everybody of this. Okay, so what saves lives? There are a few things that save lives. Good quality CPR, but I want to focus on early defibrillation. I don't think anybody would argue that early defibrillation, if you have VT or VFib, saves lives. It's clean, it's easily measurable. And this is a nice survival from sudden cardiac arrest. You can see that the chance of survival goes down by 7 to 10% every minute after arrest. And this is data actually not just from in-hospital arrest, but time to defibrillation according to when the patient was defibrillated. So a layperson or a first responder, but you can see that if you're in that first 2 minutes, you're much, much more likely to survive than if you wait. And I put a box around this because the American Heart Association, they use that 2-minute mark for defibrillation as a quality measure, and we're going to be following along with that. So what are the steps to getting somebody defibrillated early? We can just say the endpoint is got to be defibrillated. But how do you actually get to there, right? So you show up a patient's coding, you call for help, a bunch of people come, and then you have to do what? You have to put the monitor on the patient. How do you know if they need to be defibrillated if you don't put the monitor on? So placement of the monitor and pads is first. The second one is identifying the rhythm, right? If they're asystole, they don't need to be defibrillated. That's not going to help. And then once you've decided that they do need defibrillation, do you do it quickly? In real codes, I've always been shocked at sometimes, it's VFib and everybody's waiting. I'm like, defibrillate, what are we waiting for, right? Because we get excited, it's scary. So what are we gonna do to fix this? What do you think? I'm preaching to the choir here. We're going to train. And we're not only going to train, we're not going to train in theory, we're going to train in practice. We're going to walk the walk as well as talk the talk. So why do we train for this kind of situation? Well, we know that we're more prone to error in emergency situations. We know that our communication skills can deteriorate during a crisis. Our resuscitation skills can sort of tail off. We often fail to adhere to what we know we should be doing because it's an emergency and we're thinking about 100 things. We make errors in rhythm analysis, right? We delay appropriate defibrillation and we often deliver subpar or suboptimal CPR and we're not aware of it. That's the worst part. We think we're doing great, but we're really not. So OHSU started it's called SCITT, S-C-I-T-T. It's our mock Code Blue program, but it's the Simulated Code Interdisciplinary Team Training. And I really want to highlight that the word interdisciplinary, this is not one or two groups, but this has membership from nursing leaders, physician leaders, respiratory therapists, every group that is involved in a real Code Blue in the hospital. And of course our simulation leaders, because otherwise this would not be a sim, sorry. It's the Code Blue leaders and then the simulation team with this. And this, I'm gonna tell you data from before the pandemic, because this is when we had a lot more of it. What we used to do back in the beginning is we had 4 per month when I first started. 2 during day shift and 2 during night shift. How many of you guys do simulations at night in the hospital, right? It was a huge thing. You know, 50% of our codes happen at night, but are we not going to train our night teams? Yeah, well, our night shift needs to know how to do Code Blue as well. So it was great that we actually did this. It's performed in the hospital, not the simulation center, because these are in situ, and with actual members of the code team that was on call for the day. Now, they're not supposed to leave active patients, right? So if you have a patient in front of you in the ICU, you're not going to leave for a mock code. But otherwise, everyone was expected to attend and participate in this very brief sim debrief and then go back to your job. It was actually a mandate for the physicians from our pro board. And the emphasis was on cognitive-based teaching strategies and integrated skill competency, right? Do you know it theoretically, and are you practicing it in front of you? Okay. I'm going to skip through this. It's just basically saying what we're trying to do is improve safety, reliability, and patient care. And I want to show you this lovely photo of our original team. And you may notice that the members, sorry, I don't know why it's not going forward. The members of our, this is the actual, the mock code team. And so members of the on-call, the nurses, the doctors, the anesthesiologists, the pharmacists would come, but this team would be in the background recording, running the mannequin, and then doing the debrief for both ACLS and teamwork. And who responds to a real code in my hospital? In real life, you have an anesthesiologist, 3 critical care nurses, 2 of whom come from the cardiovascular ICU and 1 of whom comes from the medical ICU. A Code Blue team leader, which is typically the medical ICU fellow or attending, but could be another service attending if it's in another ICU. Respiratory therapist, bedside nurse, pharmacist, public safety, our hospital administrator on duty, things like that. The good news is, sorry, there we go. All of these people are ACLS trained clinicians. Right? So the code team doesn't hold hands and run together in the hallway, right? We show up from where we are, and the first person who might be there might be the anesthesiologist. Guess what? He or she is the code leader until somebody takes over. The nurse might be the code leader, and often, frankly, are, because our nurses come from 2 different sides and are often more likely to beat other members of the team. And there are non-ACLS certified members of the team as well, but I'll tell you, our respiratory therapists are pretty good at starting to run a code by themselves too. All right, this is what it looks like, and our 3 nurses have 3 roles: the defibrillator nurse, the documentation nurse, and the nurse who's delivering drugs. They are all cross-trained, and certainly nobody's sitting there documenting while nobody's running the defibrillator. They'll tag team those situations. And the physician lead is meant to stand at the foot of the bed and guide, but shouldn't generally be doing procedures unless there's no one else there to do it. Sorry. Can you tap it once? I don't know what's going on. There we go. So this is the process of when we run a mock code. The difference between a mock code and a real code is we know exactly when it started. We know because we're the ones making it happen. We have instability is recognized, and the nurse or whoever found the patient calls overhead or yells out, "I need to call a code blue." It's called and it's paged out through the hospital. We have overhead, and you hear that, and then CPR is initiated at the bedside, hopefully, right? And then we have these times that we're looking for. First arrival, who is the first member of the code team who comes? And you can see the SCIT team, the mock code team, we're measuring it from the moment it gets paged out. That's the time 0. How long does it take for people to come? Can you tap 4 times? Monitors placed, rhythm identified, and then the rest of the code team arrives. And then really importantly, when was that shock delivered? So in mock codes, we collect this data from first arrival to monitor placement to rhythm analysis to defib. Each of those has a timestamp, so you can see how we can follow these as process measures. So we collected data, and I'm showing you data from 2009 to 2015 because that's when the program kicked off. And there's been some changes in the interim that there's slightly different data being recorded. But as I mentioned, we collected all these time values. We also collected and assessed the teamwork of the mock code. And we also asked participants to tell us what they thought of the mock codes. Did they learn something? Was it safe? Et cetera. So this is the number of codes, mock codes, that we had by year. 2009, it was the end of the year we started, so there's only 3. So we lumped these in together. But, we had a good amount for the rest of the year. This was sort of incomplete data, but we'll get there. And so our ACLS targets, what saves lives? What did I say? Early defibrillation, right? Time to defib matters. The 3 key things, the 3 key things are from first arrival, did you place the monitor? Did you look at the rhythm, and did you defibrillate if it was necessary? I will tell you, I go to real code blue, and the monitor's not on the patient. Everybody's doing CPR. Multiple people are doing CPR, but nobody's thinking about that element, right? And that's why it's so important. It's a team effort. Also, we excluded any patient where an AED was in use beforehand, just because we wanted the rhythm ID to be clean. And get with the guideline. AHA, the American Heart Association, has a goal of less than 2 minutes from identification to defibrillation. That's their goal, and so we're measuring that as well. So, can you go forward? It's gone backwards. Okay, one more. Forward? There we go. Okay, so this is data that basically says from the first arrival, any person of the code team who showed up to the monitor placement. So our preliminary data showed that we were about 3 minutes and 40 seconds from arrival of the first person to even putting a monitor on, right? That's too long. And I think you can see visually that we had a significant improvement by the year after SCIT was started, and it was really sustained, right? We got our average number time from 3 minutes and 40 seconds to 1 minute and 24 seconds. Because in SIM, we drilled in, you get there, you make sure someone gets the defibrillator while you're doing CPR, and you put that on. You do not delay putting the monitor on, okay? And then first arrival to the rhythm analysis. So the monitor's on, and this one's a little bit, you can see a lot more splay here, but I think you can also see that we went from 3 minutes 55 seconds down to about 2 minutes for the first person to arrive to an actual analysis of the rhythm. And then first arrival to defibrillation, we went from 4 minutes and 32 seconds down to 2 minutes and 30 seconds. And again, that's not just from rhythm ID to defib, that's from the first time somebody entered the room to defib. Yes, we had a little bit of an uptick. It comes and goes, and that's a great opportunity for us to say, ooh, what's going on? Are we forgetting our lessons? Do we need to teach something differently? Right? But this is a significant improvement in SIM and how quickly we could get defib happening. So this actually is our rhythm ID to defibrillation. And I think what you can see is even at the beginning, once we saw the patient at VFib or VT, we defibrillated very quickly. The delay in defibrillation was all because of the monitor and the rhythm ID. Right? And so this is important because you might assume, oh, people, they're just waiting after they see VFib. Nope. As soon as we saw VFib, we were defibrillating. It's just we were not getting to the point where we could see they were in VFib or VT. And that's a different kind of teaching, right? You have to feed that into SIM. And there's the AHA guideline. So what we discovered in the first year of the program, first of all, our average time from first arrival to defib was really not great. And the bulk of the delay was in the initial placement of the monitor. That was really the barrier. And we fed this back into SCIT, and we said, this is what you need to focus on. Get those pads on the patient immediately. You have enough people in the room. Someone can do CPR while everybody else focuses on this. And we showed you that implementation of our program significantly improved critical actions, and 100% of our codes actually had a rhythm ID to defib time less than 2 minutes, but we didn't get the patient defibrillated as soon as we would have because of other issues. Okay, so, I'm gonna skip this. Night shift and day shift were very similar, and we're happy to say that because we did mock codes at night and during the day, I think that contributed to this. So how do we improve outcomes? So I just talked to you a little bit about ACLS, but I think we could probably agree that I could take 10 ACLS certified people, bring them together and run a really bad code because they're not used to working together as a team. So we actually also train the teamwork element, right? And ineffective communication, I think everybody knows, is a root cause of an enormous amount of medical errors. There was a perinatal study that showed 72% of errors leading to serious harm were attributed to communication errors. And in 2018 in the US, there were 2,000 patient deaths and $1.7 billion in malpractice costs that were attributed just to communication errors. So training in that part of it is very, very important. So we utilize something called CRM, or Crisis Resource Management. I don't know if anyone's familiar with this. It comes originally from the aviation industry, where you can imagine that if you don't communicate well, planes will go down. It's a guide developed to aid in emergent communication. The principles are all about problem solving, situational awareness, resource utilization, that ever important communication and leadership. And it's meant to improve our efficiency and teamwork. Okay, next one. So, one more. We use this, one more, forward. The other way, yeah. One more. Okay, so these are the main, this is a tool that we use. It's a validated and published tool. You can see there's role, responsibility, and clarity, communication, situational awareness, and decision making. Tap once. Communication, inside communication, there's orientation, directed and closed loop communication. So I like to say, I want 1 milligram of epinephrine. That's nice. Who is that directed towards? I need 1 milligram of epinephrine, or, it's not the time to be polite. We don't usually point at people, but in codes, it's okay. And then closed loop, Alicia, I need 1 milligram of epinephrine, please. Right, so she heard it, she said it, she gave it, it's in. I know it happened, right? Otherwise, I might have 3 people giving epinephrine, or no one, both of which would be bad. And transparent thinking is the difference between me, the code leader, standing here going like, okay, now do this. Now do this. And saying, okay, we are 4 minutes into a VT arrest. The patient's been defibrillated once. Get ready to switch CPR people and pull up some epinephrine. We're going to do a rhythm check. You're going to switch people. Right. I'm thinking out loud. I'm talking out loud so that everybody can hear and also contribute. Right? Maybe we're no longer on the VT-VFib algorithm. Situational awareness is always fun. Continual reassessment. Like I said, you may not be on the same algorithm throughout the whole code. Resource allocation, delegating things, and avoiding target fixation. Do you guys know about target fixation, where everybody's focused on one thing to the exclusion? I went to a real code once where 3 people were trying to get an airway on a patient. And I asked, does the patient have a pulse? And all 3 said, well, they have a rhythm on the monitor. I said, is this a PEA arrest? And 3 ACLS trained providers were just focused on the airway. Luckily, she did have a pulse, but we didn't know at the time, right? We've all done it. I'm only using that as an example because it really happens. Okay, so the tool that we use, let me see. Sorry, we're going, I promise. One more. Okay, there, okay. Every mock code that we do, we utilize this standardized, validated, published tool, and you can see each of these, you have unacceptable, poor, average, good, and perfect. I'll tell you, we rarely get perfect on anything. But one of the members of the SCIT team, who is actually monitoring these, uses this tool so that each code has a standardized review. And we're all trained in order to do this. So that you can actually numerically look at how well we're doing. So this is my own graph. I couldn't figure out how to graph it better. But poor, average, and good. And so I think you can see back in 2010, a lot of our clinical teamwork was average at best. And then over time, I think you can see that we actually made it up into the good category. Over the course of 6 years, all the category average went up from average to good. Next one. One more. There we go. And communication probably had an even bigger sort of average improvement. Communication is one of my favorites. Next one. So in summary, we improved our teamwork using mock codes. From low average to good over the 7 years that I'm showing you data from. Next slide. And then we asked participants, how was SCIT? How was the mock code, right? We're pulling people on their clinical shifts to run to a fake emergency and do their authentic role for education, right? And you can imagine that could be stressful. And we had them complete anonymous surveys. We had 807 people respond. Next slide. And so you can see here, how was the simulation? Was it realistic, right? On a scale of 1 to 5, I was included. I feel safe. Remember how we talked about psychological safety? If you don't feel safe, the learning is not going to be there. And we really prize this. When we do the debriefs, we close the door and we say what happens in SCIT stays here. The details stay here, but the learnings go out, right? That's what we do. Did we improve our teamwork and communication? Sorry, this got cut off. I learned something. This will help me in the future, right? And 95% of people thought they had improvement. It improved my ACLS or BLS, improves our teamwork, improves communication, right? People found value in this. Okay, all right, one more. Oh, and this is our obligatory word cloud. People really, really liked this. So I'm just finishing up, let's see. So did we improve clinical outcomes, right? So I said that what we're trying to do is actually improve how we do in real life. So in SCIT, our improvement was sustained. It led to system improvements in mock codes, improved response times for critical actions, such as that time to defib, right? Time to PADS, monitor, time to defib. And in 2016, the year after the data that I showed you, OHSU earned or achieved a gold status quality improvement award from the American Heart Association for our outcomes in Code Blue, which is awesome. Now, I can't say that SCIT is responsible for 100% of this, right? But percentage of patients who have a time to defib that is short is one of the key factors that goes into whether you earn these awards. Next one. So remember at the beginning I said, what are we trying to achieve, right? So what is the clinical outcome we're trying to do? We're trying to get to early defibrillation and improve survival. We know from literature that early defibrillation is associated with survival. So I don't have to hopefully prove that to you, but that's what we're trying to do. How do we do it? Well, we created a simulation program, and among other things, we focused on getting the monitor, rhythm ID, and defibrillation early. How do we measure improvement? So in simulation metrics were that time to monitor placement, time to rhythm ID, time to defib. And then our clinical metrics include the percent of VFib VT codes where the defibrillation time was less than 2 minutes. And that's something now that the hospital Code Blue team has in a dashboard, right? It literally is included on a regular basis every month, every quarter. Closed loop communication. So when we first started doing this, we didn't know that it was the monitor placement that was the barrier. And so many members of the SCIT team were also members of Code Blue leadership, and so we'd feed this back. Hey, we went to a real code, and this was the problem. And we feed it in. One of the things we found was, you know, when you put a patient on oxygen at a code, nobody was turning the oxygen on. So it's connected, but there's no oxygen. Code Blue tells us that, we feed it into SIM, and now it's part of every scenario until it becomes muscle memory, right? So think about how you're going to feed these back to simulation. It's always helpful when the same people are on both teams, but if not, you definitely need to have some sort of regular closed loop. And so this is actually data I just pulled a little bit of data from our actual Code Blue dashboard. And this is time to first shock less than or equal to 2 minutes for VFib or pulseless VT. And this is 100%, this is 80. I'd like to show you, this was COVID, right? And you can imagine that there were many barriers during COVID, including the need to PPE. But this shows us that we can and do keep track of this. Oh, and, sorry, let me go back. How do we keep track? So go back one, backward. The other way. Sorry, one more. Here we go. So in the codes, we use an app. Our documenter nurse uses something so that she or he can tap critical times, right? This was our first rhythm. This is when we defib. So we can keep track of that. We also ask for standard Code Blue documentation in our electronic health record. Now we go forward. And this is what it looks like. It's a significant event note. One more. And you can see where was the location, emergency department, acute care, the OR, the ICU. Was it witnessed? Is it first rhythm, asystole, PEA, VFib, VT, torsade? Shockable or non-shockable, right? By making this easy and clickless for our providers, you can actually keep track of this data as well. Okay, and this is what the note looks like, but it's all searchable, so we can pull this data. Last one. Challenges. So I showed you a lot of pre-pandemic data. Yeah, the pandemic was a wonderful challenge for everything. Lack of space for in situ sims. We continue to have this problem. We used to love to find an empty room. I haven't seen an empty room in I don't even know how long. There's no such thing. We do sometimes do them in special locations like the cath lab or even in the lobby, the main lobby. But also support and staff engagement. Right? Everybody, we talked yesterday a little bit about burnout, right? We're almost always asking people to do this above and beyond their other jobs. And this was just sort of pandemic. Just want to highlight that since the pandemic, we've done better. And I think that might be the end. So I want to say thank you, and also because there's members here who are part of the SCIT team from the beginning, that this is, it's an ongoing thing. It's a passion for many of us. And I just can't say enough how awesome it is to actually have been part of this early on. So thank you. Any questions? Yeah.
Big applause for Dr. Nunez for a wonderful example in the clinical improvement by the simulation. I think everyone can see the clearer picture. Uh-huh. And now I think there's a few minutes for the question. Okay.
Dr. Dean.
Thank you, Dr. Nunez. I am a part of a CPR committee. I'm glad to hear you mock post at the night time.
Yes.
Because we have ever been to mock course something like mass casualty incident mock course, but all staff complain night shift is very low manpower. Why lack of sleep? Why you wake up me to mock course? How you deal with this problem?
Well, so our leadership felt very passionate that this was important. And honestly, it's hard on night shift because the night shift team both wants more opportunities for learning, but is also stretched very thin. And what the mock codes really are meant to last less than half an hour. You do the skit, usually 10 minutes of the code, we stop it, we close the doors, we debrief, and we send people off back to their roles. I'm just throwing up here that our next phases included things like good quality CPR, right? This is not a one-time thing, but yeah, you need to have your nighttime leadership supportive of this, and to keep it short, right? And also just make it clear, if you have critical patient duties, that you have to stay and do that. But I don't know, it's tough. Yeah, I agree with you, but it's worth it, right? Because those same night shift groups have to do real codes, right? Right. Anyway, I'm happy to answer questions afterward or others.
Okay, one more.
We have one more?
From Dr. Pakon.
I heard you expert of ECMO. In Oregon, do you have ECMO CPR in court?
ECPR?
ECPR.
So, yes. So Dr. Bishoy Zakari, who's the ELSO education lead, he's actually one of my faculty. And we have both at OHSU and the Pacific Northwest a variety of programs. OHSU is in the process of developing our eCPR program now. We don't yet have enough providers to cannulate 24/7, so that's the infrastructure is being put in place so that we can do this effectively.
Oh.
Yeah, it's exciting.
Exciting.
Yeah, I'm happy to talk to anybody outside of this because we have a lot of mechanical ventilation, clinical improvement, and other ICU things. So anytime.
Yeah. I think it's.
Oh, I'm sorry.
มีใครที่อยู่ทางบ้านอยากจะถามคำถามไหมครับเราเปิดโอกาสให้ครับ
code.
มีไหมครับ
จาก RPH ค่ะ
RPH okay from Royal Hospital in Phnom Penh from Cambodia โอเค
Oh.
น้องถามภาษาไทยก็ได้ครับหรือจะถามภาษาอังกฤษก็ได้ครับ
สวัสดีค่ะ Good morning. My name is Supha. I have a question about what do you think about the ICU announced code 8? We have not code blue, but we have code 8.
Now we use the code 8 instead of the code blue in
Got it.
OHSU.
This is a
Yes.
mock code in the ICU, right?
It is not the mock, but it is really announced code 8
Oh,
in
I'm
ICU.
sorry.
The code 8 is for a hospital wire. Yeah.
Yes, so internal to the ICUs, we may or may not call for an overhead code because we are the code team. We encourage if any ICU wants or needs more help, because sometimes if you have a high acuity ICU where all of my nurses have one-to-one patients and somebody codes, we don't have enough people. We may need more help. We may need an anesthesiologist. We may need someone else. But often in the ICU, my ICU patients are already intubated. They're just, I don't want to say just coding, but we have the right people around us. So we have internal code blue where we hit the button, everybody comes, but we can overhead announce and call it out to get more help. And there's no shame in that, particularly anyone here work in a surgical ICU. So often, if you're in a specialty ICU, it makes more sense for the code team to come run the code while you do the surgical things or the neurologic things, right? Why would I waste my surgeon who needs to do a chest tube running a code? That's my job.
I think
Alicia?
I can add to the response to that. So for care areas that run their own codes and don't call a code 8, that staff gets annual training similar to this so that that team internally maintains their competence, which is how it first started before SCIT, and how SCIT was created was that those teams were getting individual disciplinary training. And so they get their individual internal training, And then they are also, to Stephanie's point, the members of the actual Code 8 team too, and they get this training more regularly as a big team.
And I just want to say, since if we do this once a month, twice a month, if you have 10 people show up to a mock code or a real code, there's always going to be somebody who's newer. But if 90% or 80% of the members know what they're doing, then you can see how they can learn, right? If 80, 90% of the people had never been trained, that's chaotic. But if 10%, 20%, and the rest of the team knows, that's a learning opportunity for them.
I think the most important is you need to look at the clinical outcome. If
Yeah.
your team doing well, it's okay. But if there's something wrong, that you have to find out what is the problem, and if there is something like a team working, the simulation will solve the problems. But if they don't have the knowledge, sometimes just only the lecture is okay.
Yes.
Right?
Yeah, and when we first started this, we didn't have role clarity amongst the system about who did what. So it started with the nursing teams within the hospital systems to come up with what were those roles, and that's how I came up with 3 Ds, right? And then once that was determined, there was enough foundation to then build from that. But when we first started, we did our assessment, and there would be 70 people going to a code, and nobody knew what they were supposed to be doing. And now there's structure, and there's role clarity,
Yes.
and we are very clear about what we're trying to measure from an outcome in the organization.
Should be one code leader.
One code leader instead of
One
5.
team, yeah. Thank you very much. I think today we learned a lot from Dr. Nones, and thank you very much for a very good example for us to know how we can improve the clinical outcome